Welcome! In this module on yellow and dengue fever, we will review the etiology, epidemiology, and transmission of these two diseases. We will then discuss how they present clinically and what diagnostic tests we have at our disposal. Finally, we will discuss treatment options and preventative strategies. Let's start with a few questions to get you thinking about yellow and dengue fever. We will review these questions at the end of the module to give you a chance to apply what you have learned. Question 1. What is the vector for both yellow and dengue fever? Question 2. What are the reservoirs for yellow and dengue fever? Question 3. What is the common arthropod-borne viral disease? Question 4. Why is yellow fever, quote, yellow? Question 5. What is Fagé sign? Question 6. What is, quote, breakbone fever? Question 7. What is, quote, saddleback fever? Question 8. What are the severe complications of dengue fever called? Question 9. What antiviral agent is used for treatment of yellow and dengue fever? And question 10. How long does the yellow fever vaccine provide protection? Let us start with yellow fever. Yellow fever is a viral hemorrhagic fever caused by Pfisterophilus tropicus, an enveloped, single-stranded RNA arbovirus belonging to the flavivirus genus. It is, in fact, the original flavivirus in the Flaviviridae family, which also includes dengue virus, hepatitis C virus, West Nile virus, Japanese encephalitis virus, and the other encephalitidae viruses. Flaviviruses take their name specifically from the yellow fever virus, which is derived from the Latin word for yellow, flavus. Yellow fever has its evolutionary origins in Africa, where the virus made an interspecies jump from primates to humans. The virus and its mosquito vector were brought to the New World by the slave trade during the European colonization of the Americas. The first probable outbreak of the disease in the Western Hemisphere was recorded by Spanish colonists in 1648 in Yucatan, Mexico, where the disease was termed psiquic, or black vomit, by the Maya. Eventually, the disease spread to North America, with a number of epidemics occurring throughout the 19th century in New York, Philadelphia, and New Orleans, among others. Quote, Yellow Jack, as it was known in the United States at the time, is shown on the right as a sailor knocking at the gates of New York. After significant losses amongst U.S. forces from yellow fever during the Spanish-American War in the 1890s, U.S. Army doctors led by Walter Reed, shown here on the left, were the first to demonstrate that the disease can be transmitted by mosquitoes, a historic biomedical discovery after colleagues allowed themselves to be deliberately infected by vectors that had fed on patients with yellow fever. This disproved a long-held belief that yellow fever was transmitted by contaminated body fluids and excrement. As a result of disease control programs in many countries, yellow fever is now endemic only in parts of sub-Saharan Africa and South America. It is estimated that there are about 200,000 cases a year, resulting in more than 30,000 deaths annually. Yellow fever is transmitted by female mosquito vectors. In Africa, the Aedes species, particularly A. aegypti, or tiger mosquito, is involved, while in South America, the Hemorrhagic species is the dominant vector. Aside from human hosts, yellow fever also has a natural reservoir in primates. The symptoms of yellow fever manifest themselves after a short incubation period of 3 to 6 days and classically unfolds in 3 stages. The first stage, or period of infection, is one of severe, nonspecific signs of systemic illness, corresponding with viremia associated with fevers, malaise, headache, photophobia, nausea, vomiting, and myalgia, especially in the knees, for a period of days. Tender hepatomegaly may also be present, as well as Fagé sign, described as pulse temperature dissociation, whereby there is relative bradycardia despite high fevers. Moreover, the tongue may develop characteristic erythema along the tip and sides with a central white coating. The second stage, or period of remission, follows with clinical improvement. For the vast majority, or 85% of cases, the disease ends here. For the unlucky minority, or 15%, the respite ends after 48 hours. The final stage, or period of intoxication, is marked by the return of symptoms seen in the first stage, but further complicated by jaundice, hemorrhage, oliguria, and metabolic encephalopathy. One unique feature of yellow fever is a predominantly AST-elevated transaminitis as opposed to an ALT elevation typically seen with most viral hepatitis. Hemorrhage, as a result of thrombocytopenia and inability to synthesize coagulation factors due to hepatic dysfunction. Mortality rates for those that enter this stage ranges between 20 to 50%. Yellow fever is diagnosed most commonly by serologic testing using ELISA to detect IgM antibodies against the virus. Additionally, yellow fever can also be diagnosed using PCR to detect the presence of viral RNA in the stool and/or tissue. Treatment of yellow fever is unfortunately limited to supportive care, given that no known antivirals have been shown to be effective. Yellow fever can be effectively prevented by a live attenuated vaccine that offers protection for 10 years. It was developed in 1951 by Max Tyler of the Rockefeller Foundation, which earned him the first Nobel Prize ever awarded for the development of a viral vaccine. Mass vaccination programs against yellow fever have since been initiated by the WHO in endemic countries. In addition, it is recommended that all travelers to endemic regions be vaccinated prior to travel. Now let's turn to dengue fever. Dengue fever is a viral disease that shares many commonalities with yellow fever. Both belong to the flavivirus genus. Both are vector-borne illnesses by the Aedes mosquitoes. Both have natural reservoirs in humans and primates. Dengue fever is the most common arthropod-borne viral disease in the world. Globally, 2.5 to 3 billion individuals live at risk for the illness across 112 countries in the Americas, Africa, Asia, and Australia, resulting in 50 to 100 million new infections a year. Population growth, overcrowding, poor sanitation, and ineffective mosquito control have all led to an expansion of the geographic distribution of dengue fever and a subsequent increase of worldwide incidence. Like yellow fever, the symptoms of classic dengue fever manifest themselves after a short incubation period of 5 to 8 days and unfold in 3 stages. The first stage is known as, quote, break-bone fever, and is characterized by the acute onset of fever, headache, retroorbital pain, and severe myalgias and arthralgias for 5 to 7 days. Hemorrhagic manifestations due to thrombocytopenia are common, including purpura, petechiae, scleral ecchymosis, shown here on the left, epistaxis, and gastrointestinal bleeding. Other associated symptoms include rash, as shown on the right, cough, sore throat, nasal congestion, nausea, vomiting, and diarrhea. The second stage is a period of remission, whereby fevers resolve, but significant fatigue can last for days to weeks. The final stage is known as, quote, saddleback fever. It is seen in a minority of patients with classic dengue fever and is marked by the resurgence of fevers for 48 hours. The feared complication of dengue fever is the development of dengue hemorrhagic fever, or DHF. The WHO have developed 4 criteria for the diagnosis of DHF. The first is marked thrombocytopenia, less than 100,000. The second is hemorrhagic tendency or spontaneous bleeding. Hemorrhagic tendency is measured using the tourniquet test, which is performed by inflating a blood pressure cuff to the midpoint between the systolic and diastolic blood pressures for 5 minutes and observing for the appearance of greater than or equal to 20 petechiae per 2.5 centimeters squared. The third criteria is plasma leakage syndrome, which is due to increased plasma permeability resulting in greater than or equal to 20% rise in hematocrit, pleural effusions, and or ascites. Another component is fever. And lastly, in severe cases, this can further progress to dengue shock syndrome with hemodynamic collapse, carrying a mortality rate of 12%. Dengue fever is generally a clinical diagnosis. When available, serologic testing is the initial diagnostic test of choice, though false negatives may occur early in the disease process, less than 1 week. Therefore, if clinical suspicion remains high despite a negative serologic testing, antigen testing for viral RNA or NS1 antigen should be obtained given higher sensitivity, 50 to 70% during this time period. Treatment of dengue fever is supportive care, particularly with volume repletion and blood products should plasma leakage syndrome or hemorrhagic manifestations occur. Vector control is the most effective preventative measure available against dengue fever, which includes protective clothing, insect repellent, and targeting mosquito breeding sites. No vaccine against dengue fever is available at this time. Let us turn now to our pre-module questions and see what we have learned. Question 1. What is the vector for both yellow and dengue fever? The answer, mosquitoes. Question 2. What are the reservoirs for yellow and dengue fever? The answer is humans and primates. Question 3. What is the common arthropod-borne viral disease? The answer is dengue fever. Question 4. Why is yellow fever, quote, yellow? The answer, jaundice is a common manifestation of the disease. Question 5. What is, quote, Faget's sign? The answer, pulse temperature dissociation in yellow fever. Question 6. What is, quote, breakbone fever? The answer is severe myalgias and arthralgias seen in early dengue fever. Question 7. What is, quote, saddleback fever? And the answer is the recurrence of fever after a period of brief remission in dengue fever. Question 8. What are the severe complications of dengue fever called? Dengue hemorrhagic fever and dengue shock syndrome are the severe complications of dengue fever. Question 9. What antiviral agent is used for treatment of yellow and dengue fever? The answer, there is no specific antiviral agent available. Question 10. How long does a yellow fever vaccine provide protection? The answer is up to 10 years. And this concludes our module on yellow fever and dengue fever. Thank you very much.